So now let's talk about transplant. How many of you have had a stem cell transplant? No, but I will soon. No, but I'm considering one. No, my doctor tells me I'm not a candidate, or yes. So we have quite a few people here who've had transplants, so they can certainly jump in and correct me and speak to it, I think, in a very unique way. And for the group who haven't yet, again, I would also encourage you to talk to them. They're great resources as well as us. And for those of you who are considering, again, same thing, talk to us, talk to people who've been through it. Hopefully they can tell you from the other end that it is not as frightening as it sounds when you first come to see us. One of my patients once told me, he came to see me, and he didn't have myeloma, to be fair. He had a different kind of disease. He said, you spent 40 minutes telling me all the bad things and 10 minutes telling me all the good things about transplant. So, I think I've reframed my transplant talk a little bit now. But, I do think the first visit you come to a transplant center is very overwhelming because we only have an hour to give you all that information. And it's really a process, and transplant's a process. But as I said, the first part, introduction to it can be very overwhelming. So I give you all credit for coming here this morning to start on that process of sort of gathering the information. So, let's start with sort of a case, and there's really no classic case, but just some generalities. Someone, good health, low back pain, and usually it seems a lot of people play golf around here, so it's usually people notice it because they start playing their golf. They start getting back pain. They can't go out on the course. And they get eventually get an MRI. This patient shows compression fractures. That led him to his oncologist. So his primary care doctor was very astute and realized that this is not something natural for someone to have 3 compression fractures. His oncologist did all the tests Dr. Cole told you about in terms of the M spike on the electrophoresis. Did our favorite test, the bone marrow biopsy. I didn't put in the cytogenetics here, but let's just say that this patient had normal cytogenetics. He got the treatment that Dr. Chari told you about, our 3-drug regimen, the Revlimid, Velcade, and Dex. He achieved a complete remission. So again, Dr. Chari told you that now almost 100% of people are going to respond to their initial therapy. And even more exciting, many of those people are going to go into complete remission. Then they decide, that's sort of their first branch point. It's sort of the first exit off the freeway. Now, do you come and talk to us about transplant, or do you just keep driving and say, I'm going to stay on this road for now? And that's kind of where we come in to help you make that decision. So first of all, let's just talk about transplant. What does that mean? It's certainly all over the press. There are many different kinds of transplants. So, the fancy name for it is, we no longer call it bone marrow transplant. I mean, we're lazy. We still use that vernacular, but it's really just because we don't want to say hematopoietic stem cell transplant. But that's really what it is. Hematopoietic is a fancy way of saying blood-forming stem cells. The idea behind it is pretty simplistic. It's a way to give high-dose chemo to kill more myeloma. And the drug we use is a drug, it came out of London, actually, the Royal Marsden Hospital in London, 1981 or 82. And I have a picture. I still save that. I told you I'm a real myeloma geek. Dr. Cook is he's one of the pioneers of myeloma from London who did this procedure. We met him at the International Myeloma Workshop in India. When they did that, back then, they didn't have any stem cells, so they didn't know how to rescue people. So people had no blood counts for up to 2 months. So while it worked, obviously then you suffer the side effects of having no white count for over a month. And so clearly, until we were able to figure out how to get around that we were not able to use that routinely. But now we certainly can in regards to the use of autologous stem cells. So what does it work? And transplanters, we're pretty simplistic people. And I love this slide. I got it from my boss, Dr. Foreman. And it came on this idea, really, of you give more drug, you kill more cancer cells, right? But at some point, and the problem is, first, you're going to hit all the other cells in the bone marrow, right? So the good cells, the white cells that fight infection, the red cells that carry oxygen. You keep giving more drug, though, at some point, you're going to get here where you start causing toxicity to the other organs, so lungs, liver, and heart. And really, the biggest one here is your liver. Your liver is where you detoxify most of your chemotherapy. And if you get to certain incredibly high doses of chemo, you're going to you see toxicity here. So what you're trying to do is find this area. So we don't care about this anymore because now we have stem cells, right? We can rescue you with that. But we don't want to get to here either. So we need to find a spot in here. And that varies depending on the disease you have. So for example, leukemia. So the leukemia doctors, I feel bad for them. They do not have as many drugs as we have, really. And in fact, for many, many years, all they really had was 2 drugs and transplant. So that's why, if you may know people, and you may have seen them in the hospital, patients with leukemia, they get a much more intensive transplant regimen. They often get total body radiation plus high doses of chemo. We really whack them hard. So they're really closer on this curve here. But myeloma, we're fortunate now. We don't need to hit you as hard with that because we have all those drugs, first of all, to get you in remission before the transplant. And second, you heard a little bit about this from Dr. Chari, this idea of maintenance of consolidation after the transplant as well. So we can be a little bit closer to this part of the curve now, which makes it, hopefully, transplant certainly much safer, but also hopefully in terms of side effects and tolerability, much more tolerable for patients. Now, Dr. Chari alluded to this concept when he talked about minimal residual disease, this concept of iceberg theory. And this is probably the most famous slide. It's from my colleague, Dr. Laniel, who made it. And it's really, again, the idea that he talked about. When you start out with myeloma, there's a lot of myeloma. We talked about all these great induction therapies, carfilzomib, Rebdex, RVD, and we also heard you can get most people into remission. But then why are we not saying, if we can get 100% of people responding, why are we not curing 100% of people? And that's the idea. There's this disease lurking below. And part of the rationale for using high-dose chemotherapy is to get patients from here down to here. And you can argue the closer you get to here, the closer that we're going to be able to use the word cure. The other part of this now, and you'll see this more and more, and you're going to hear this more and more, this idea of minimal residual disease, and it's going to be one of our hot topics because that's really down here what we're talking about when we testing to really detect 1 in a million myeloma cells in the body. And really at some point now, and we're in fact talking about a trial right now that I'm hopefully chairing throughout the US. It's going to be MRD-directed therapy after a transplant. So really transplanting patients and then using MRD to decide who needs more therapy, who can we start to back down on therapy. So you never hear us say back down before, but now we're recognizing maybe there are people who don't need prolonged therapy. So I told you this a little bit, but now you see it sort of in numbers, right? So the Center for the CIBMTR, which is a national registry, international actually, they collect data on everyone who's had a transplant from centers that participated. You can see that we're doing more transplants in older patients, and in fact, the group over 70 here is a really a nice chunk of our patients now. Good news here, too. You see these numbers, and we don't even have the update from 2015 to present yet, but survival is getting better in terms of transplant for patients with myeloma. So now let's talk about the kinds of transplants. So, autologous, fancy way of saying your own stem cells. Allogeneic is stem cells from a donor. And just kind of for your own edification, this is blown wide open. So again, when I started in the field, allogeneic just meant brother, sister. That's it. Then it meant a donor, so unrelated donor. And my boss, Dr. Foreman, always tells me the stories of like the helicopter flying into City of Hope with bone marrow. And even more, this tells you how medicine's changed. Some of my older colleagues tell me these stories about when they first started doing transplant at City of Hope. They would admit patients for 3 days for their pre-transplant workup. So all that testing you guys know that we do in one day, you'd sit in the hospital for a week getting a bone marrow, getting a CAT scan, getting an echo. So life has changed a lot. And now part of the change is we don't just use brothers and sisters. We don't just use unrelated donors. We use cord blood. We use half matches. So things are moving very, very quickly in the transplant field. The other big thing is stem cell source. And now we no longer, when I started as a fellow in Boston, we used to have to go to the operating room and collect bone marrow, from bone marrow harvest. Even in patients using their own, we would collect it from them. And we don't do that anymore for autologous transplant. We collect it from the peripheral blood, and we'll talk a little bit about how we mobilize it in there. And then we've sort of looked at many different ways in myeloma. Are we better off doing a mini allo, so a reduced intensity conditioning, so sort of using mini doses of chemo and reinfusing donor stem cells? Maybe if one transplant's good, maybe 2 transplants are better. And we've done many studies, which we'll touch on, trying to answer that question in myeloma. So first of all, how do you collect stem cells? So as I said, we no longer take people to the operating room, which is good. Hematologists hate the OR. I think that's why we went into hematology and did not become surgeons. We don't like being struck. We don't like being sort of stuck in a room but ultimately, really, obviously, it's a lot more morbidity to someone to have to undergo general anesthesia, to have someone do a harvest from you. If you think about one bone marrow biopsy, a harvest, we go on each side 50 times. To collect bone marrow. And the other part of it is when you reinfuse those, it takes a lot longer for bone marrow cells to work than peripheral blood stem cells. So we were moving ahead to peripheral blood stem cells was a huge leap forward in the field. The way we do it, and every center does it slightly differently, and I'd be curious to hear what Dr. Cole and Dr. Chari's center does, but we used to, in fact, the City of Hope used a lot of Cytoxan. So you remember, you'd come on a Friday, we'd give Cytoxan, then you'd start on those shots, those Neupogen shots, and then come back 10 days later. We've moved away from Cytoxan now as a mobilization based on some of these national studies suggesting that it doesn't add a huge amount in terms of benefit, and certainly many of you know the side effects of Cytoxan. And so really our practice now has been just Neupogen, so shots daily. And then sometimes we add another drug that we also kind of pioneered one of the early studies on, Mosabil. So what Mosabil does is those stem cells are stuck in your bone marrow, and they're stuck with a receptor. What Mosabil does is it blocks that, so it basically unsticks them from the bone marrow so that they come out into the bloodstream. And then we collect them with that procedure called apheresis, which is where you come to our donor room, and we use a machine. It's basically a big centrifuge that spins off your stem cells, and then we freeze them. And then we get to the actual transplant that I'll show you a little bit about in terms of how that's changed, but we give the high-dose melphalan chemotherapy, followed by reinfusion of the stem cells, and then recovery. So again, the nice thing about this part, too, is certainly we've had new formulations, Evomela, some of the supportive care drugs in terms of nausea prevention, much better now than even when I started in this field and in terms of the melphalan. And I think many of you can speak to us in terms of better in terms of the tolerability of it. And then infusion of the stem cells. So part of what we do, though, is, we try and collect enough for 2 transplants. It's sort of like money in the bank. We do less and less second transplants now just because we have so many new drugs. But it's something that you like to kind of have in reserve if you need to. Often what we end up doing, and I know this from some of my colleagues at other centers, we've tended to use some of those stored stem cells down the road if many of these chemotherapy can affect blood counts. So sometimes we use it as a way to boost up stem cells as well. And occasionally people who've had very, very long remissions from their first transplant, at least 3 years. I saw someone who had 10 years from their first. We will think about doing a second transplant because, again, transplant really has the longest track record in terms of durability for someone like that. Now let's talk about sort of the side effects of high-dose chemotherapy. And and again, I'd encourage you all during the break to talk to some other people who've been through this because, again, it's easy for me to say it, but, obviously people who've really been through it can tell you, I think, in much more reality terms. The nausea certainly is something there. We talked a little bit about the new antiemetics. Diarrhea is certainly very common. So the way chemotherapy works, it affects any cell in your body that's dividing rapidly, right? So that means your hair. That's why the diarrhea, your GI tract, mouth sores sometimes, and obviously the low blood counts that we talked about. takes about 10 days by the time after we infuse the melphalan. 11 days later, the white count will come up, and we kick you out from the day hospital, usually around day 13, day 14. But that doesn't mean, as you well know, that you're feeling really back to normal. And part of this is just understanding that it still takes time for your body to really feel. Fatigue is incredibly common. But having said that, trying to do things to start getting back in your regular routine is very important. So part of the reason we moved to the day hospital too is just in terms of your own thing. If you think about it, there's been studies showing if you lie in a hospital but every day, it only takes 2 weeks to really lose a lot of critical muscle mass. So, even just walking from the village apartments to the day hospital every day is something. And when you get home, we encourage people to continue that with walking. Big thing that when you get home is infection prevention. So I said that most of the infections you get are from your own body. But when you go home, your immune system's back. But now the biggest infections, think about it, are people around you. So it doesn't mean you have to live in a bubble, but it means, cold and flu season. Tell all, your friends and family they should be getting flu shots. People, hand washing, the biggest thing. And those of you who have little kids, as you know, they're the biggest germ factories. And so, constant hand washing with them around is clear. Avoid crowds. So this is not the time, if you're just out of your transplant, that you really want to go to the Black Friday sale at Target. Yeah. So, and then in terms of your myeloma, the biggest question is obviously everyone has it. In fact, most people ask this the week later that they come back for the follow-up visit. Did it work? Did it work? You got to give it time. So we don't restage until at least 6 to 8 weeks after the transplant to see the effects. And in fact, it can take up to 3 months to see the full effect of the high-dose melphalan on the myeloma. And now let's talk about this consolidation maintenance idea. So that's kind of what I alluded to before, is this idea that we give you a big whack of chemotherapy, we knock the myeloma down, but then maybe we need to do a little bit more after that. And often we use some of the same drugs we used before at the beginning of the treatment, after the treatment as well. That's what we call consolidation, where it's still somewhat intensive in terms of schedule. So in fact, we had a trial where we used RVD for 4 cycles after the transplant, and then maintenance therapy. So consolidation, and I'm not going to go into the weeds in the interest of time, is very controversial. We did a huge trial that I chaired in the US of 700 patients where we showed that consolidation didn't seem to make as significant a benefit as just doing a single transplant and maintenance therapy. On the other hand, and this is where everything is always a challenge, our European colleagues did an equally large trial where they showed that consolidation did seem to help after the transplant. So we're kind of still left trying to figure that out. Maintenance therapy I'll touch on, but just to tell you that the body of evidence suggests that maintenance therapy is a good thing. And we have now data on thousands of patients suggesting maintenance therapy can improve survival after a transplant in myeloma. So it really tends to be a standard of care for us. And this is the trial that I was talking to you about in regards to, it's called a meta-analysis. So meta-analysis, fancy way of saying looking at a huge number of patients. And so this trial looked at the use of Revlimid or lenalidomide maintenance after transplant, which I know that I would suspect many of you are on. And it becomes the question, why are you on it? And it's really because of this. And in fact, because of this, the FDA approved Revlimid for maintenance fairly recently. So this was the CLGB. So not to begin, this is the trial that we participated in at City of Hope, and some of you may be in on it, where patients are randomized to a placebo, so assigned by computer after their transplant to placebo or to lenalidomide. The French did the same thing with somewhat nuanced differences in the study design, and then the Italians too. The other thing I wanted to touch upon here, just this question we'll get into, do I need a transplant? So the Italians tried to answer a lot of questions. So first question they tried to answer is, do I need a transplant? So they gave people standard chemotherapy for half of them. The other half got a transplant. And in fact, they showed the people who got a transplant did better in terms of staying in remission longer than those who just got standard chemotherapy, even the ones who went on to maintenance therapy. So this, for transplanters, was a very landmark trial. All these trials, as I said, had an arm where they put people on lenalidomide maintenance therapy. And I didn't put it in here, but overall survival from this was increased by 2.5 years for patients who stayed on maintenance therapy. And I can tell you from this data here and now, patients that get a transplant followed by lenalidomide maintenance, the overall survival is about 8 to 9 years now. That's an average. So that, again, that tells you that patients on both ends of that spectrum. So we are doing much better, and obviously we want to keep that getting even better for patients. So this is kind of touches on this question, and we get this question a lot. And you know, and it is, do I need a transplant? You told me I'm in remission, so you know, I'll come and listen to you, but you know, this is not for me. Or the question of, well, if I do need a transplant, when do I need it? You know, and so this was the trial that Dr. Cherry alluded to, and this was a trial between the United States and France. It's called the IFM Dana-Farber trial, is sort of our nickname for it. And it tells you that it's a challenge to do these studies because the good news is people are living a lot longer with myeloma. Now, if you're a statistician, though, it's a challenge because it means to actually see a difference now between whichever treatments you choose. You need a huge number of patients. So this was almost 1,000 patients. Everyone got that treatment that you've heard about already, the RBD. Everyone had stem cells collected. And the reason this is important is because if you're thinking about not having a transplant, you need to recognize that being on long-term Revlimid makes it harder to collect stem cells. So that if you're going to think about delaying your transplant, at the very least, you need to think about collecting and storing your stem cells. People were randomized, so assigned again by a computer to either getting a transplant or staying on RVD. They incorporated that idea of consolidation, and then they put people on maintenance therapy. Now, one important nuance here is in the US, we tend to give maintenance until it stops working or if you have side effects. In this trial, they had to compromise with their French colleagues, so they only gave it for 18 months. And then if the patients who didn't get a transplant relapsed, they were allowed to get and encouraged to get a transplant at relapse. And what they found was that if you got a transplant early, you stayed in remission longer. So for those of us who are transplanters, that really cemented for us the fact that RVD followed by transplant and followed by maintenance therapy really it remains the gold standard. For those of you who for those of us who didn't believe in transplant, they've kind of pointed to this question here. Sure, that may be true, but overall survival wasn't different between the two arms. And so that raised a lot of debate. And you know, the way I look at it is this. Number one, this may be true, but in reality, this group of people who didn't get a transplant initially, 80% of them ended up getting a transplant when they relapsed. And the 20% who didn't, a portion of that, and a good portion of that was because their disease became so uncontrollable, they couldn't get to the transplant. They became too sick, first of all. The other thing about this is that maybe that 4 years is not a snapshot enough. Really, you know, what we should be looking at is 8, 10 years from now. Because, again, people are living a lot longer. And if we keep following those groups of patients, that, you know, ultimately my bias and belief is that we are going to see that this arm is going to really reign superior. So, you know, I would say that transplant still remains a big pillar of myeloma therapy. And then the question is, doing a second transplant, does it improve outcome? I'm not going to talk too much. I think I'm running out of time here. But just to say there have been many, many studies doing that. It's no longer, so the BMT-CTN trial, this is the one I was alluding to that I chaired, looked at 1 versus 2. And really we found that 1 followed by maintenance lenalidomide was equal to 2. So we don't do 2 transplants outside of a clinical trial, but we collect enough cells for 2. Mini allo transplants, so that I also did this trial back in 2003 thinking a transplant from a donor, so a new immune system. I saw a lot of questions about the immune function. Maybe if you give you a new immune system, that will help. So this trial we did an autologous, so used your own stem cells. Then we followed it up about 2 to 3 months later with a transplant from a donor, with a mini transplant, we found that, in fact, it made no benefit because of the side effects of doing a transplant from a donor. So we really don't use that approach, except, and we do about 300 allos in the United States for myeloma, except for a group of people who have really, really high-risk disease. You heard this from Dr. Cole in terms of genomics, in terms of the 17p deletion, in terms of very, very young patients. Those would be groups that we still consider, and we do have a trial for that. And I can tell you, that's something we only really do in the context of a clinical trial. And then this just kind of a summary of, obviously, what I said earlier still holds true, that we're still trying to do better. And we're looking at many, many different questions about induction therapies, the treatment before the transplant. How do we make that better? And then many, many trials looking at treatments after the transplant. And we're going to open one at City of Hope, hopefully next month, actually, using daratumumab, the monoclonal antibody, after the transplant as a maintenance consolidation strategy. And then we have multiple, and some of you are on some of the trials right now, looking at Ninlaro as a maintenance strategy. And then this is one of the checkpoint inhibitors, one of the new drugs that Dr. Cole talked about that's been looked at as well. And immunotherapy, and I'm not going to say too much because Dr. Tutt's going to talk about CAR-T vaccines. There's a trial going on right now giving patients vaccines after the transplant to try and augment the immune system and keep myeloma in remission. So really, to sum it up, these are the questions to ask the doctor. Am I a candidate for transplant? You know, I would suggest that most patients are, or at least should have that dialogue, and that dialogue you should have with a transplant doctor, because even the community doctors are terrific, but they don't do the procedure, and so, you know, you really need to go to talk to someone who that's what they do. What's the best time to undergo it? We talked about, again, how many transplants does your center do? How long will I be in the hospital? We touched about that. And when do you go, what kind of lifestyle adjustments do you need for that? And then I think you're already doing this. You're all here. Learn about myeloma. Things become less scary when you kind of have more knowledge about it. Ask your doctor about the treatment options and side effects. Support systems. So we all need support systems right now. Friends, family. You can't do this alone. And try and maintain some of your normalcy of your life, I think, because you don't want myeloma to be kind of the front and center of your life. You want it to, you know, eventually be in the back, really, and trying to keep the rest of normalcy as much as you can, I think, really helps with that. And then, you know, it says travel, so I get this all the time. Everyone seems to have a vacation planned, and I would say go for it, you know, obviously with some nuance behind that. I mean, this may not be the time that you want to go to Zimbabwe to that remote, you know, safari camp, but, you know, going to other places, you know, certainly are things that we can work with you in terms of making that a very doable goal for patients. And then these are many, many different resources to help with that. So just in conclusion, basically autologous transplant, as I said, still remains a standard of care. We do over 7,000 autologous transplants for myeloma in the United States. We're getting better at it. Safety is equivalent to the RVD chemotherapy now. And I showed you that data suggesting that early transplant certainly can lead to longer remissions. Thank you.